I suppose the most important death that has occurred in my family is my father passing. And that was a long and complicated journey. He developed throat cancer, and for that he chose to undergo all the available treatments, which included radiation therapy, chemotherapy, and then surgery. And finally he was cured from the cancer itself, but he was left with issues relating to swallowing. And surprisingly, accidentally, he died from a choking episode. It was very tragic for me because I felt, firstly, as the daughter, but also as a doctor, that I didn't do enough. How could I have allowed this to happen, this horrible accident, after all what he had been through? This was the first time in my life I was truly grieving. And I realized that grieving process, it's not a day or a month, but it takes years. But we all get through it. For a long period of time, I tried to blame somebody. Why did this happen? How could this happen? I blamed myself, I blamed my sibling, I blamed anyone that I could, but someone had to be responsible for this death. It didn't just happen randomly. I really wanted to attach this feeling of responsibility. But what I learned over time, and this is what really took some time, but I applied in my medical practice as well, what if the choking episode didn't happen? What did the next day hold? Death is so uncertain. It can happen at absolutely any time. The only thing is, once we're born, we know that we're going to die. Any given day could happen to any of us. But really the reality is, any given day, something else could happen. The way my father died, it was sudden, unexpected. He did not suffer, he did not struggle. The date was unexpected. The timing was unexpected. His life, I felt, was cut short. But let's say, what if he didn't die on that day? And he lived on, but he would have had a recurrence of his cancer. And then he would have had to endure another round of chemotherapy and radiation therapy. He was already tortured by those medical treatments so extensively. Could he have coped with another one? Was he actually blessed? He died with family around, my sister was around. Was he blessed that he had a nice sudden death? And we don't know. What I've learned from this is, when I look at my patients and when something unexpected, sudden happens, I don't necessarily think it as a bad thing. I think, okay, this young person or old person struggled a lot. Unpredictable, unfortunate that it happened so quickly. But we don't know if we got through that single hurdle on that day and somehow we avoided that, what the next day would have held. And maybe it would have been worse. It's really my second year as a doctor, so a year after internship. I was placed in remote hospitals and remote communities where I used to work. I really started firstly seeing death, but also being in a position to making decisions around how a person dies and where they die. So one of my first and earliest experiences was in a small mining town, where a 90-year-old woman, after having a heart attack, expressed her desire to stay in the township, close to her family, grandchildren, and pass away in this tiny little hospital. Now, my perspective, because I've been placed there from the big city, is that, hang on a second, if you were in a different hospital, you would have all these different options of having a few stents put in, not a big procedure, relatively small thing, and that could prolong your life by X number of months or years. And these medical options were available. But what I learned from this very initial experience very quickly, that what I thought was best for a patient or a family, that family was able to communicate to me clearly that, actually, hang on, doctor, I am actually close to 90 years of age. I like where I live. I'm happy to be in your hospital, even though you're not a big specialist doctor, you're a very junior doctor. I'm very happy with the care I'm receiving, and I don't want to be going to any big cities. It was rather challenging for me, because I felt that it was my duty to make sure that a patient received the best possible medical care. But it somehow, in a very beautiful way, the extended family was very supportive of us coming up with a mutual decision for this grandmother. That person didn't live very long, maybe 2 or 3 days later passed away in this tiny little hospital. And the family was so grateful that I even received all these gifts and kindness and letters and words from the family on how grateful they were for me to be able to provide the care that I could, even though I was not an expert in this field, but allowed a peaceful passing of that elderly woman. The big difference is in remote communities that the medical facilities are really basic. Most of the communities don't even really have a hospital, they have medical clinics, day-stay clinics rather than overnight facilities. So that's a big difference in relation to the quality of medical care that we can deliver. And of course, as a doctor, that is the perspective that I'm coming from. What is the quality of care that I can deliver in those settings? And obviously it has limitations. But from a patient perspective, it's completely different from what I've experienced. Remote patients who barely speak any English. English is often their third or fourth or fifth language. They're not familiar with the big cities or what they call the big smoke. To go to a bigger city to get better quality medical care or end-of-life care or active medical care, whichever way you look at it, it comes at a great sacrifice. It's sacrificing being at home in a country where you feel comfortable. It's sacrificing your cultural principles or your potential place of death. But perhaps most importantly, that separation from your immediate family and from that culture. And I think that's the really critical part. When I look at my own potential mortality, it would be scary to be dying alone in a place that you're not familiar with, being around people who you don't know. I think it's kind of a basic human desire to pass away or to die, being close to your loved ones. The biggest cultural difference in relation to Indigenous Australians is really how comfortable they are with the idea of dying. Life in remote Indigenous communities is very different from life in an urban Australian setting. The biggest differences I see is when a person passes away or dies, the entire community mourns. They don't just attend funerals of their immediate family members. Indigenous people attend funeral for anyone who died within their community. That means they experience life, birth and death much more frequently. I think for myself, I attended my first funeral maybe when I was 25. Now most children in Indigenous communities, they would have attended hundreds of funerals by the time they become young adults. So that kind of discussion around death is much more common, much more normal, and it's also seen. So they see it, hear it and feel it. It's a very normal part of living. I mean, that is the only thing that is certain, that we are all going to die. But it's not something to be afraid of or not something to shy away around discussions. And I think the key thing is that they see it. They're part of tradition that truly celebrates people's lives through funerals that go on for weeks or sometimes even months. So it's not just like a one-day event in a calendar. In any given remote community, there might be a funeral every single week. It really becomes part of the day-to-day rituals of life. Firstly, as a doctor, and especially as a doctor looking after children with heart disease, obviously my ultimate day-to-day goal is to prolong life, to prevent death. And it's such a common scenario where we in a full treatment mode, and the plan is to try to provide as much active care as possible. And then once we reach a certain stage and realize advanced medical care can no longer be to the patient's interest, then we swap to a palliative care mode. So it's almost like two different modes we have, either full go ahead or put the brakes on completely and stop. And the thing is, life is not black and white. It's easy to envisage if a patient is in a palliative care mode or an active care mode. But reality, that most of the time in life, you're somewhere in between, and it's a spectrum. So that's a really challenging part of delivering end-of-life care, when My primary purpose with my patients is to provide active care and to prevent death. So I personally find it very challenging to be switching between those two modes. If it's black and white either way, that's easy, but that grey zone, it's very difficult and it's very challenging to communicate. It's obviously absolutely tragic when a young person dies, and especially when a young person dies from a preventable disease, and when that young person dies from a preventable disease in a rich country. None of those patients should ever be facing death so young, so prematurely in a first world country. So they're kind of the challenges that I face. Rheumatic heart disease is a really unfortunate disease because there is surgery to make the heart better, to fix the doors in the heart, but the reality is that once you had one open heart surgery, the road looks like repeated open heart surgeries every 10 to 15 years. And when you have your first surgery, maybe 5 to 8 years of age, there's only so many times you can stop the heart, cut the heart open, go inside and fix it. There are some people who had 4 or 5 open heart surgeries, but the reality is second or third surgery is probably what most people's bodies can bear. So once you had your first open heart surgery for rheumatic heart disease, unfortunately you're lucky to get 15 to 20 years extra. So in some way, end-of-life care should almost start at that time of the surgery. But that seems too pessimistic. And it's not just having that surgery, because even after having open heart surgery for rheumatic heart disease, the reality is that these young people will need painful monthly injections for the rest of their life. So they go on this long treatment that is painful and for the purpose of prolonging life to a certain number of decades. So it's very tragic because as soon as I talk to my patients and their families about their first surgery, in my mind, I've got this map on what the future looks like. But I'm always remain very optimistic. Maybe just this time the statistics don't fit. And maybe this patient will have a long and fulfilling life. Maybe they have their own families. Maybe they can have children as well. But knowing all well that the statistics are stacked against the patient. As through medical school, we learn many different skills. But unfortunately, in the current era, in current medical schools, we learn very little thing about dying and death and palliative care. Once upon a time, it was really common, even in established economies, to see young people passing away. But these days, death in established economies are really rare events. It mainly occurs in the elderly and often happens in a predicted way. If let's go back, let's say 50 or 100 years ago, all across the world, 1 in 9 women used to die during childbirth. Many children never met their mothers. Living and dying, birth and death were closely linked. And as doctors, medical students, junior doctors, this exposure to death was very common. And that's how junior doctors learn how to talk about death and how to deal with death and how to plan for death with the community. But now medical students like myself, when I went through medical school, I was not exposed to any experiences like that. And it wasn't really until my second year as a doctor that I had to deal with it. And when I did have to deal with it, I had to deal with it by myself because I was a solo practitioner in that township. So it's really about how can we teach medical students to be able to have open discussions on how to deal with this whole process of dying. Death, in the majority of the settings, it still feels like a failure for me as a doctor looking after kids. It's easy to bring up conversations around death when you're talking about statistics or probability. It has now become a normal part of medical legal life that each time a person has an operation or any procedure, we have to say, look, you got 0.001 chance of dying. So we're very confident and very comfortable to bring up a death as a statistic because it is required of us. But it's very challenging to bring up death in a way that, look, we have exhausted all options and now we need to switch modes. The question is not about prolonging life, but providing quality of life. And that's especially challenging when we're talking about young patients, when we're talking about children, when we're talking about people who haven't had a long and fulfilling life. We're talking about people whose life been cut short for whatever reason. And that's where the real challenges lies, both as a doctor bringing up those conversations, but also on the other side, the family accepting that conversation. And you get various responses. You know, some families, and the idea of a doctor bringing it up, it gives the impression that the doctor has given up on a child or a patient. And how can you do that? So it can be met very angrily from a family because it gives that appearance that we are not trying hard enough. Is that all you can do? Those kind of emotions and questions coming up. There are interesting arguments and philosophies when we look at how much doctors should get involved with the process of dying. So if you look at some settings around the world, maybe some resource-poor countries or really remote areas, unfortunately many people around the world simply do not have access to palliative care, good pain control and good control of various distressing symptoms. On the other hand, we have big cities in Western countries where doctors' preference is for patients to die in a hospital setting which is highly controlled and optimal medical therapy can be delivered in a safe place. So there's two extreme examples of what's happening in the world today. Some people are getting too much medical attention in a highly hospitalized tertiary setting, while other people are getting no support at the time when they need it the most. So I think the balance is somewhere in between primarily that meets the need of the family and the patient, and how can we provide additional medical support during potentially distressing and painful times and avoid hospitalization. Because I think it's fair to say that most people would like to die at home rather than in a hospital. Sometimes there's advantages in being hospital if certain symptoms are out of control. It's a really challenging situation to see. Firstly, if you look at the health expenditure, 90% of our health expenditure is spent in the final 12 months of people's life. So that's a pretty distressing figure just from an economic point of view. But secondly, to see people close to their end of life having repeated surgeries of various kinds for very minimal gain. So that comes at distress to the patient, pain, hospitalization, isolation from their families and homes and their cultures. So it's a really difficult balance, but it's not just the medical professionals to be blamed for this. I think that's a really important part. There needs to be a greater engagement between the medical establishments and communities. The number one job of a doctor is to save a life and to make people better. Unless patients and their families have created a clear plan that they would no longer like to uptake active medical care, a doctor is almost forced legally to continue to carry out the highest possible and highest standard of medical care, even in a person where it's clear that it might not be to their overall benefit. So these are really difficult and challenging discussions to have with the families for each individual who is close to their end of their life to come up with an advanced medical plan. Unless there is an advanced medical plan, our hands are tied by legal procedures, because our requirement is to do everything that we can humanly can. So that's the real challenge. It's the real challenge where we need to have the legal system involved, the medical system and an overall community on how can we kind of together negotiate this and move forward and provide the highest possible quality of life in a person's final 12 months of life. We often face with these kind of situations around, life and death. We're going with the intention, of course, of saving every single child's life, which is my aim and my job. Sometimes surgeries don't go as well as they should have. Sometimes surgeries are complicated by strokes or some really nasty complication for a young person that would leave them disabled and potentially dependent on a life support machine. And when we come to these situations where, for example, a young child is on a breathing machine, on a ventilator after an operation, they're meant to have been successful but wasn't successful as intended, there comes a time when you have to make a decision about turning the machines off. And this situation is not infrequent. And the challenging part is, as a doctor, is really around when to bring up this conversation. Is it on day 1, day 2, day 3, 7 days, 14 days? How many days into this journey when you think, okay, there's no way out of here? And how to bring it up? And it's very challenging because a day or two beforehand, you might have spoken to the parents and said, look, you've got 99.5% chance that everything will go well. And that 0.5% chance situation arose. And now when we break it to the family, it's often in disbelief and shock, and often get in this situation and say, doctor, can you just give it another day? Can you just give it another week? Maybe another month and the brain will recover. People want to hold on to hope. They want to hold on so tight. Even if there's a 0.0001% chance, maybe this miracle will happen just to their own child. And as a doctor, you would know, but even if a miracle happens and some brain function recovers to the point that the child will be able to breathe on its own without a ventilator, we know that there's not going to be any quality of life. We know that the child won't be able to walk or talk or feed themselves or go to the bathroom. This is a journey of negotiation between a family. When can we call it quits? And it's challenging as a doctor because we feel we failed. We know we failed. It's not even just a feeling. We know that this should not have happened, but happened. And how can we come up with now to move on this new journey and focus on not the past, not what happened the day before, but this is a situation. This is what we are stuck with. How can we deliver the best possible care? It's been very challenging, the COVID-19 times all around the world, including Australia. In Australia, we were very fortunate that our healthcare system wasn't overstretched compared with some of the other countries. The key lessons that we have learned, or the key lessons that I've learned from the COVID-19 pandemic, is firstly around the importance of keeping families together. So one of the devastating things that happened in Australia, but in other countries, and when people were dying or in their dying days, they were isolated from the rest of their family members, and family weren't allowed to visit. Now, it became a trend that people used to say goodbye over Zoom meetings. And that's not how most people would like to say goodbye to their loved ones. That was terribly distressing for the doctors, nurses, medical professionals, but especially for the families. I think a key lesson from the COVID-19 pandemic, that connection is important. The place of death and who you would like to be around when you say your final goodbyes is significantly more important than an extra day or two of life. And we learned that the hard way. We learned that through public policies that force people to be isolated in their final hours of their life. We also learned during the pandemic that the global medical resources are limited, and sometimes tough decisions have to be made. Who's the most suitable candidate for a certain treatment when you have limited resources? So that was really a first time in the Western world that doctors had to make those tough decisions. Of course, in majority part, the global population, those decisions have to be made all the time. So we were kind of reintroduced to reality's life, and we were reintroduced to the idea that doctors are actually not in charge of someone's time and place of death. The whole system that we live in, we create our own destinies. There's definitely such a thing as good death, in my opinion. I think connection to culture, family and place is something that a lot of people would share, and obviously a reasonable control of symptoms that sometimes can be distressing, painful, unpleasant. Yeah. Palliative care is such an important part of a holistic medical care for someone's journey in life. So we got specialised people for birth, obstetricians, and that specialty at the end of life, which often ends up being in palliative care, unless you have sudden unexpected death, is a very critical part of the medical care we provide to a single person through their life journey. It is not a big part of the medical curriculum. It's not well taught, and it's not really valued equally as other subspecialties. For example, we're much more likely to be learning about oncology and chemotherapy and radiation therapy rather than what do we do once we have exhausted all the options. This should be part of a standard medical education, and not just a day or two, but a big proportion. This is especially important with the next generation of doctors coming through, where death is actually a less frequent event, fortunately delayed until the 7th or 8th decade of life. That is the really challenging part. The line between active care and palliative care is not a strong black line. It's often a fuzzy little line, and sometimes crossing back and forth between those situations as well. So this is where specific training on how to deal with this would be really valuable, because I think on either end of the spectrum it's pretty straightforward, but we're seeing increasing number of patients who kind of fall and move between those lines. It used to be a case that every doctor used to have this skill set. It was part of being a doctor. A doctor did everything, did the postmortems, but delivered the baby, looked after obstetrics, and palliative care was a major part of it. But now we have become so subspecialised, it's almost only the patients who see a palliative care physician actually receives good palliative care. But if this was incorporated into other specialties, then we would serve our patient populations so much better. As a doctor, I'm not in charge of when someone dies and how they die, but it's really a good leader, a good politician should listen to the community. A good doctor should listen to the patient and the family. Palliative care, end-of-life decisions are team decisions. As a doctor, I'm a servant to the patients and to the public. This message is so important to understand that doctors are not gods. I suppose my personal experiences really changed my outlook on a single negative event that leads to death. I no longer focus on the blame and to try to put a finger on exactly whose fault it is, but really focusing on the potential blessing. So turning it around and looking at it from a positive way. Yes, a bad event has happened, but if that didn't happen, something worse could have happened, potentially. I suppose I look for the silver linings at time of very distressing situations.